I'm Bob Bonow from Northwestern University and Northwestern Memorial Hospital in Chicago. There's some pretty important key takeaways regarding the timing of intervention for valve disease. First, for mitral regurgitation, it's got to be subdivided as best we can into those patients who have primary disease of the valve, degenerative disease versus those patients who have primary disease of the ventricle with secondary functional MR. For primary valve disease, we want to operate early. These patients should be identified because these valves are usually repairable. They should be referred to centers that can guarantee a high likelihood of repair. And if so, we could even begin to refer asymptomatic patients who've got severe mitral regurgitation. Clearly, patients who have symptoms, patients who have LV dysfunction, patients who have pulmonary hypertension or atrial fibrillation should be referred for surgery. Optimally, however, we should identify those patients before they have those endpoints and refer them earlier for patients, for surgeons who can guarantee a high likelihood of valve repair. For secondary MR, for functional MR, it's a different kettle of fish. These patients primarily have heart failure. There we want to treat them optimally with medical therapy or biventricular pacemaking. Resynchronization therapy, if they're candidates, because that may lead to reverse remodeling and improvement of ventricular function, in which case the regurgitation may also improve dramatically. It's only in those patients who have failed medical therapy who become candidates for mitral valve repair, unless they're also undergoing other forms of surgery, like coronary bypass surgery, and have functional MR, in which case one would also address the mitral regurgitation at that point. For aortic stenosis, it's a very rapidly evolving field. Here we tend to also wait for symptoms, but in asymptomatic patients who have severe aortic stenosis, where it's highly predictable that these patients will require surgery over the course of the next 4 to 5 years, there is an important judgment call, alerting the patients that they have a high likelihood of requiring repair. For an 85-year-old patient, one might wait for severe symptoms, but in a 60-year-old individual with very significant aortic stenosis, many times we're moving toward early replacement, only because the likelihood of a patient requiring surgery is so high in the short term.